We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
Frequently encounter is deficiency of calcium and vitamin D, which is the usual scenario. And what we do is we just give treatment and wait for the response to therapy. We give calcium, we give vitamin D therapy and wait for the response. So the problem occurs when the child does not respond to your treatment. So rickets can be classified as a simple deficiency of vitamin D and calcium, and refractory rickets, which usually does not respond to your first line of management. So this is when we start thinking about refractory rickets. So what comes under refractory rickets is actually calciopenic, which can be because of alteration in the calcium metabolism. So you think about vitamin D dependent rickets type 1 and 2. This could be because of renal failure or even in cases of malabsorption. So what are the clinical pointers or cues which make you suspect about calciopenic refractory rickets? Is it has very early onset, as early as in infancy. The children have very high parenthormone levels and the calcium levels is low. So Another reason for refractory rickets is because of acidosis, which you can see in both proximal and distal type of RTA. And the clinical pointers in this situation will be the child will have polyuria. So these are the, you can say, the clinical cues which should, along with rickets, the clinical features of rickets, which should make you think about refractory rickets as the reason. There will be failure to thrive, which we very commonly see with the acidosis, RTAs, and the child may have nephrocalcinosis as in distal RTA. So I'll come to that. Another aspect is where there is absorption problem in the phosphate levels. So there you can have phosphatemic rickets. So what comes under that is hypophosphatemic rickets, or even Fanconi's, or the hypophosphatemic rickets along with hypercalcemia. So the clinical pointers, they will have a late onset, comparatively late onset as compared to the calciopenic type. And the characteristic pointer here is that the children, they have more frequent involvement of the lower limbs. So which should make you think about refractory rickets. And another important clue or cue here is that their parathormone and calcium levels might be normal. Okay, so the question that you should always ask in a child who presents with this limb deformities is whether that is rickets or something else. And if at all it's rickets, it's refractory or amenable to your first line of management. So I'll try to address these questions. So talking about the management aspect, so we had guidelines which came out in 2021, IAP guidelines. So this is very easily available, so you can find that. So what that recommends, the take-home message, an important point to remember here is that parental vitamin D, which is very, very frequently favored by practitioners all over, is not a very good form of management. Yeah, thank you. So it's only for whenever you suspect malabsorption. Otherwise, giving oral dose and daily therapy is definitely proven to be of more advantage and benefit as compared to your intermittent regimes or even your IM regimes. So once you start a child on treatment, so what are the clinical point? How does the child respond? So what happens? You start vitamin D as per the age appropriate dosage. It leads to calcium absorption, which is its function, and phosphate absorption. So what happens because of this? So what you need to remember here is there is influx of calcium into the bones. So the serum calcium levels might go down. So if you go for biochemical testing prior to the designated time, so you may have calcium levels in the low range, and which might have a manifestation of bone pain. So this does not mean the child is landing into failure, but this is a usual, you can say, response to therapy, which is physiological once you start a child on therapy. And because of this supplementations, there is increase in the osteoblastic activity. So that leads to increase in the level of serum alkaline phosphatase. So what we understand is ALP days means the child has rickets, but you have started the child on treatment, but still the levels are high. So this could be a physiological response, and you should not rush to conclusions and label it as refractory rickets. So there might be a transient rise in ALP. And in your X-ray, you'll find a line of healing. Radiological appearance of a healing rickets is very important, just to suggest that you are on right track. So these are the pictures you may have. As I said, in refractory rickets, there might be involvement of lower extremities more. So you may have all the abnormalities confined to the lower limbs. And you can have, depending upon the weight bearing on the joint, you may have further radiological evidence like the characteristic cupping, fraying, and splaying. So once you start the child on calcium and vitamin D source, but you wait for 4 to 6 weeks, but still there is no line of healing. So it's not always refractory. So there are certain misguiders. As I said, you may have high alkaline phosphatase levels. You may have normal low calcium levels, which is a part of your therapy. And the child may have bone pain along with that. So don't you may suspect, but don't jump to that this is refractory rickets. So what can be the masqueraders of refractory rickets? Dysplasias, skeletal dysplasias, hypophosphatasias, and fluorosis. So they may have manifestation which might mimic refractory or any kind of rickets. So you should always, this calls for a detailed clinical history and examination. Okay, so you may have other conditions which may have clinical features suggestive of rickets. So red herring signs, which again the repetition of what I said earlier, polyuria in a child who has multiple fractures, unexplained fractures, and who has failure to thrive. This should make you think about rickets as the etiology. So talking about management, so that depends upon the condition. As I said, it could be because of calcium, because of phosphate, or even the involvement of in cases of renal जो है acidosis. So depends upon the condition. Definitely for RTAs, like the treatment is bicarbonate and phosphate supplementation. For vitamin D dependent rickets, that depends upon whatever the problem is, whether it's at the receptor level or problem or abnormality in the enzyme. So that calls for high dose calcitriol, that is vitamin D analogs along with calcium. So coming to one very unusual and unaddressed form of rickets, that is hypophosphatemic rickets. So how do you treat that? Once you label a child as a case of hypophosphatemic rickets, in which it could be autosomal dominant, I'm not going into details of that, or it could be because of X-linked hypophosphatemic rickets. So you have to give phosphate supplementation in a dose of 40 milligram per kg per day. That has to be titrated, and you have to monitor. So how do you have to adjust the dose? So giving like it's not just calcium and phosphate. Now you're thinking beyond that. So you give phosphate and you keep titrating the dose. Similarly for calcitriol and calcidiol. Now alpha calcidiol, it's used mostly in cases of like renal involvement, renal failure, because it gets converted into activated calcium, vitamin D in liver. So it does not require renal involvement for its activation. So that is helpful in those situations. But the doses are very important. And another important aspect is monitoring. Why? Because you are giving activated form. So you have to, you don't have to overtreat. So you always have to monitor that you do not overdo the treatment. Okay, so what are the different phosphate and phosphorus preparations available? So you have oral preparations available, tablet form, you have in sachet form, and also I'm sure you all of you must be aware of the Julie solution, which is available, which provides about 50 milligram of phosphate per ml of solution. And you have injectable preparation also. Depending upon the case, you have to start the child on treatment. So how do you monitor? So these are the parameters that should always be addressed in a child who is started on phosphate supplementation. So you have to monitor growth, very reliable clinical parameter. And if it's not increasing, then definitely the dose has to be titrated. You have to monitor biochemically phosphate levels every 3 monthly, and likewise as given in the chart. And accordingly, the dose has to be adjusted. Always remember to monitor, like in simple rickets, you never monitor urine routinely. But in this case, you have to monitor urine for calcium creatinine ratio, for the reason being, again, you don't overdo, because giving increased doses might lead to increased phosphate levels, calcium might lead to calciuria, and it might lead to nephrocalcinosis. So keep monitoring and keep titrating the dose accordingly. So what can be the complications? So complication, very sinister complication could be hyperparathyroidism, because you are perhaps overtreating, and the child has, because of overstimulation, has landed up into hyperparathyroidism, which could be because of high phosphate levels if you didn't monitor, or because of low calcitriol. So these can be reasons where the child can land up into hyperparathyroidism, and which could be counterproductive in this case. So what you have to do, you have to reduce phosphate levels, obviously, and you have to, and at times, if it doesn't respond to the just reduction of dose, so take care of the the parathormone levels, you might need to give cinacalcet also. So nephrocalcinosis is another complication which we are always wary of. So you have to keep monitoring urine calcium creatinine ratio, so the child does not have something iatrogenic. It could be because of high calcium and phosphate levels. So you have to just monitor it through annual ultrasound, or if the child has abdominal complaints, and that needs to be addressed, and that can be by talking about drugs, so that can be corrected by giving thiazide diuretic. So child with rickets and being giving thiazide. So this is always another important take-home message. Another complication that you might encounter is the child may have growth failure if not properly managed. So you have, it could be because of delayed diagnosis, very common in our scenario, in our setup. So you have to, most of the children, they are often brought late. So you have to keep that thing also account while counseling the parents before embarking on treatment, that growth failure is a part, and because they are already late, so it might compromise the adult height. It could be because of poor control, though the drugs are available, but at times follow-up becomes an issue. And here follow-up is very important because you have to keep titrating the dose. And renal dysfunction is another reason for that. So how do you rectify those? So you have to aim for a better control, better monitoring. So talking about growth hormone, like children, because of refractory rickets, because of the deformity per se, they may have short stature, which could be disproportionate short stature. So growth hormone, because it's being used in so many indications. So talking about renal rickets and refractory rickets and growth hormones, so we have mixed studies. So the robust evidence that says that it doesn't help much. So it might be used, but it's not like you have both kinds of evidence available. Few are favoring while other refuting, but the evidence says it doesn't help much in this situation. So again, about hypophosphatemic rickets. So here I talk about a case. So we have a child who is a diagnosed case, who has been started on phosphorus with the baseline dose that I talked about, who is on calcitriol 30 nanogram, and talking about phosphate levels are normal, low, and parathormone levels on the higher side. So what is the plan? Anybody from the audience? So he's already on treatment. Parathormone levels you monitor still high. Okay, so go back to the chart so go back the thing that I was talking about. So it could be because of hyperparathyroidism. So improper giving a too high a dose, high phosphate might lead to parathormone stimulation, might lead to hyperparathyroidism. So again, the remedial measures would be to reduce the phosphate dose. So that has to be titrated. So that is the importance of titration. And you have to increase the dose of calcitriol. Okay, so this is how you monitor. So the same child was followed up after 2 years. Phosphate was reduced from 40 to 30, calcitriol again 25, 30 to 25. The child now complains of polyuria and abdominal pain. So what next? What could that be? Pardon? Okay, very good. So that's okay. So you go for urine calcium creatinine ratio, that's 0.6, and the scan shows renal calcification. So obviously the diagnosis becomes obvious that the child has developed nephrocalcinosis. So perhaps you were high on the dose. And for that, what do you add? You add thiazide to take care of this hypercalciuria. Okay, so that was added to the child, and the dose of the calcitriol has to be reduced further. So again, the child was followed up after 1 year. Phosphate, again, 30 milligram per kg, calcitriol 25. Height. So the earlier height is not given, but I would say poor growth velocity. His testicular volume is 4 ml. So what's the plan now? Poor growth velocity. So the third situation, poor compliance. Okay, the child is landing up into growth failure. So again, maybe he was not following up properly. Maybe he was not taking the drugs properly. So again, the third scenario, the third complication that we talked about, that the child may have growth failure. So you have to talk about better control. So that has to be monitored. You have to ensure compliance of the drugs. You have to counsel the family. And growth hormone, as I said, that remains plus minus. That remains a gray area towards a no indication. So what is recent? So we have now a new drug. You can say new. It was approved in 2018 for X-linked hypophosphatemic rickets. Burosumab, that is a monoclonal antibodies, because now we are living in a generation of immune therapies and these drugs. So this is available. So if you recall that for all kinds of hypophosphatemic rickets, the problem is at FG3. The phosphatonase FG3 levels. So what they do, the levels of these increase because of many reasons, because of mutations. So this has phosphaturic effect. So that's why the child lands up into phosphaturia. So what is this burosumab? So this is an antibody which works again, which takes care of this increased FGF23 levels. So that takes care of phosphaturia. Okay, so the levels gradually become normal. So whatever the phosphate levels which was being secreted in the urine because of burosumab, it gets reduced because that's its line of action. So that takes care of the nephrocalcinosis, and also it has a stimulatory effect on the calcitriol. Okay, so that will take care of the hyperparathyroidism, which could be the complication of the drug. Okay, so the indication, but it's not very, though it's available, but it's not a very like simple drug that you can give in any child with hypophosphatemic rickets, because there are few indication and also contraindication like in any other drug. So for newly diagnosed and even X-linked hypophosphatemic rickets, and also for malignancy induced tumor induced phosphatemia, so you may give burosumab, but the catch here is always look for serum phosphorus levels. So the levels should always be low before you start this treatment. And another important recommendation and precaution here is that you do not have to give calcitriol and phosphate along with that, because it might lead to dangerously high levels of phosphate. So once you diagnose a child as X-linked hypophosphatemic or tumor-induced osteomalacia, you can give this drug, but the serum phosphate level should be low. And if the child has been on treatment, then these two things have to be stopped at least for a week prior to starting this treatment. Okay, and the contraindication would be a renal involvement. So if the child has renal failure, so definitely this drug is contraindicated, because again in renal failure you may have hyperphosphatemia, so this might increase it further and cause the problems. And you can give normal doses of vitamin D along with burosumab. Monitoring has again to be with growth, because but if the cases are very extreme, like in cases of delayed diagnosis, you may have that bony deformity that might persist for a long period, and that might require orthopedic correction. But you have to just monitor how the child is responding. If obviously the epiphyses have not closed, and you have to monitor biochemically also. And you have to try to maintain in the lower normal, the phosphate levels have to be maintained the lower normal level, so that you do not overtreat. So there might be high risk of dental abscess. That's it. So talking about another reasons for refractory rickets. So vitamin D dependent rickets. So that depends upon, this is, I'm sure everybody knows, vitamin D gets converted into 25 hydroxy and 22. Okay, I'm running short.
Request you to just wrap it up. Thank
Okay, so I'll just come to the treatment part. So you have to give calcium in vitamin D dependent, depending upon the case, and the activated form of calcitriol, which might be like in type where you have resistance at the vitamin D receptor levels. So those has to be high. So that is what has to be given. And talking about the same thing like vitamin D resistant rickets type 2, where there is problem at the receptor level, so doses has to be high. You have to give calcitriol, and the dose are higher as compared to in a normal situation where you give. And this might require initiation with IV calcium also, but subsequently the child can be switched to oral calcium supplementation. So vitamin D preparation, all of you are aware what are available. So the take home message is just oral is always better, and the daily dose is always better than the intermittent. Greater rise, because we have different types of, you have ergocalciferol, you have cholecalciferol, so response is always better. So greater rise with cholecalciferol, no advantage of parenteral vitamin D except in special situations like malabsorption. And this is the same thing, I think I can skip. Okay, so monitoring. Okay, so I'll talk about, this is the same thing, repetition of the same thing. You have to give calcitriol high dosage along with calcium, and you have to keep monitoring. Monitoring has to be, and just remember, apart from calcium phosphate, alkaline phosphatase, you have to monitor urine for calcium creatinine ratio. That is very important. That should be a routine part of your monitoring, because you should not overtreat. X-ray has to be repeated at least for after 4 to 6 weeks to look for line of healing. And if it doesn't appear, revisit your diagnosis and recheck whether the child is taking proper dosage or not. So this is again the same thing, type 2. So you have to give calcitriol in high dosage, IV calcium, subsequently switch to oral calcium. So this is the same thing. Monitoring again, calcium phosphate, alkaline phosphatase, the same biochemical parameters, but how to play around with them is very important. How to titrate doses is very important. So you have to look for age appropriate normal levels. And so we have 3.5 years old with refractory rickets. So okay, so what is your take here? Calcium, the low side, phosphate, low, alkaline phosphatase on the high. No response to parenteral therapy. Go back to the same flow chart. Okay, 25. Hydroxy is low, definitely on the lower side. So that could be 25 hydroxylate deficiency. So, okay, I think this is the same thing. So I want to go to the the RTA part. The last part is about, so what happens in the proximal as well as in distal RTA. The proximal, it's because of the increase in the secretion of phosphate level, bicarb levels. And in the distal RTA, you may have problems at the secretion of this proton pump, hydrogen ions, which might lead to RTA. So this is amenable to treatment. So once you have a child who presents with polyuria, who presents with failure to thrive, and who has this feature lower limb involvement and disfiguration of the lower limb. So you have to, and the clinical, as far as biochemical parameters, electrolytes, you have hypokalemia as the manifestation. So you have to think about RTA, and the treatment has to be with alkali preparation, soda bicarb, that depends upon proximal or distal. You have to give bicarb preparation. So you have sodium, potassium, polycitra, which is a powder form tablet, easily available, potassium citrate. So again, that has to be given, and the dose has to be titrated. Okay, so your target would be a bicarbonate, which should be in the near normal level, 22 to 24 millimoles per liter, and the dose has to be initiated again for distal RTA. You might require a bit smaller dose. It has to be initiated at 4 to 10 nanomoles per kg per day, and the dose has to be titrated depending upon the response. Preparation, as I said, it's sodium potassium citrate is available, soda bicarb for hypercalciuria, which might again lead to nephrocalcinosis, especially in distal RTA. So you have to go for low salt diet along with thiazide diuretics to take care of that. So urine calcium creatinine ratio is the monitoring for every form of refractory rickets. Annual ultrasound, again, to look for nephrocalcinosis is very important, and renal functions. These are in addition to your normal biochemical parameters. And for proximal RTA, because this is because of the defect in the child passes like amino acids and glycosuria and bicarbonaturia, everything is there. So you have to give treatment for that. Again, the treatment is bicarb. So this is along with the vitamin D preparation that has to be given. It is because of the faulty secretion of the hydrogen ions. It is characterized by, again, hypokalemia, but the nephrocalcinosis and hypercalciuria is not so frequently seen as in distal RTA. So dose, again, has to be 10 to 15. It is a bit higher. You have to give nanomoles per kg per day. And to take care of hypercalciuria, thiazide diuretics have to be given. Potassium, the usual requirement, 2 to 4 milliequivalents per kg per day. And the phosphate, roughly 40 to 50 milligram per kg per day. And you have to keep monitoring. There are chances because the condition predisposes for hypokalemia. So you have to keep monitoring for that. You have to give analogs of vitamin D as in any case. And the child subsequently improves over time.